guiding us into the guests of honor, Dr. Anita Gupta, Dr. Arun Gupta, and Dr. Vivek Jain, and dear friends. We now have a few cases for the panel discussion. They are common cases which we deal with in our daily practice. And to help us solve breastfeeding problems, we have an array of stalwarts as panelists. Dr. Anita Gupta, who was part of the task force for BPNI modules. She has been trainer for WHO and UNICEF. And Dr. Kusum Sahni, who's a well-known gynecologist of North Delhi, working for Fortis Hospital, Shalimar Bagh. Dr. Leena Sreedhar is head of academics, Manipal Group of Hospitals, Dwarka, and a very active member of DGF. Dr. Vishal Jain is a HOD Neonatology at Manipal Hospital, Gurgaon. He has a fellowship in neonatology from Sir Gangaram Hospital. We have Dr. Surekha Jain. She is Director Jain Medical Center and Secretary DGF North. Dr. Manjusha Gupta, Secretary DGF Northwest. Dr. Asha Hans is Director of Hans Charitable Hospital, having a huge turnover of deliveries and gynae patients. And last but not the least, Dr. Manishikha, who is a lactation expert and an antenatal program manager of Mamma Mia at Fortis Hospital, Shalimar Bagh. So welcome once again, all dear honorable panelists. We start. Why do we want to know anything about breastfeeding? Because something as simple as breastfeeding could save 1 million children a year. Coming to the first case, which goes to Dr. Leena. Pooja, 35 years old, para 1, life 1, comes to you 7 days after her delivery. She's anxious and she says she's producing less milk as her baby cries a lot and always seems to be hungry. Now, Dr. Leena, we want to know from you, how do you assess that breast milk supply is adequate for baby or is it less? Over to you, Dr. Leena.
Yeah. Thank you, Dr. Divya, and it's great to be on this platform with all the stalwarts there. And you've asked me a question which is, I think, so very common. It is something which we always see when we go, when we know the patient comes back to us, say after her delivery in the first very follow-up visit. In fact, it is so very important, first of all, to make the patient, the anxious patient, to reassure her. She has to understand that, 99% of the time, nothing is really wrong. What happens is they lack in confidence because, you can't see how much of breast milk is going to the baby. You cannot measure it. So every mother, most of the time, and especially the first time mothers, seem to think that there is a less amount of, milk that is going to the baby, and a very anxious case, my baby growing, am I doing correctly? Added to that, there are well-meaning relatives at home who keep saying, "Tera bacha to ro raha hai, tu kuch kar kyun nahi rahi hai, you're not feeding." So there, there is some, it's like, enforcement. If you keep telling a person you're not feeding properly or you're not taking care of your child, eventually the person starts feeling that is the problem. And that again adds to the psychological element. So the first thing I tell her is sit calmly. In all our OPDs, we have baby feeding rooms. So I tell them that, you sit down calmly, have a drink of water, calm down, and then attempt to breastfeed. And there's no point if you're anxious, because that's going to affect your prolactin levels. And I try to explain to them, and most of the time it works, because I think anxiety is the first thing. Then I would ask her, okay, how many times are you breastfeeding? Because frequent breastfeeding is what is going to help her to have the milk let down. Now, all these questions can be quickly asked, in an OPD. It's not that we require the lactation consultant to come and, assess her. It's only when, patient is not understanding or is not hasn't got the point across. Now, if she says, yes, I'm feeding, say, roughly around 8 to 10 to up to 12 times in a day, 2 to 2 hourly frequent feeding, and the baby is latching on and the baby goes to sleep, then if it's a term baby, most of the time what we can say that yes, she is feeding her baby properly, and baby is also wetting. I mean, baby is not dehydrated in the sense that at least 6 to 8 times, you're changing the diapers. And so, the baby is not dehydrated. So you have a good idea that she is feeding the baby properly. And when a baby comes after 7 days, as we all know, in the first week, there is a small loss. So again, we can weigh the baby and assess in case there has been a very big weight loss. So hello. Yeah. So we can assess that also, and we can reassure her. And I think this is important that we address this, because I had one baby, one mother who came just very recently, and she had developed a little bit cracked nipples, So she had, this, we have to tell them that these are some small problems that you can face, and what to do if it happens, So the mothers take this message home that these are very normal problems and they will be addressed. That, sort of reassures her and brings the anxiety element down. So that is, I think, the first thing that I would do, and I would assess this way that the breast milk is adequate for the baby.
Thank you, Dr. Leena. That was an excellent roundup. So of how you are going to allay the anxiety, you're going to watch her breastfeed, and you're also going to assess the baby. So what are the causes of low milk supply? Are there any things that we need to look at besides?
Yeah, so the main things which I've seen is that, mothers are too quick to get on to the dabba. Like Madam just mentioned that, you would be surprised that, when you get your bag ready for the delivery and you've been asked to put in the clothes and all, there's always this thing about, getting the dabba. So it's always like that people are like mothers feel that, they go on to giving supplements and don't have that, confidence that they are feeding the baby properly. And there could be periods of, maybe interruption, or the baby was sent to the NICU, which sort of led to a gap between the mother being able to feed the baby. And that also could be one of the reasons why there is a low supply. And engorgement, then small issues like, the nipple pain, there may be cracks. That also can be one of the reasons why she is not feeding the baby.
Yes. Thank you, Dr. Leena. Dr. Vishal Jain, who's a neonatologist, could you tell us how would you assess the baby, whether the baby is getting adequate feeds from the mother or not, because she's come after 7 days and she is really anxious. So we send the baby across to you also to have a look and tell us. Dr. Vishal Jain.
Yeah, ma'am, if the baby is passing urine at least 6 times in 24 hours, and that means the baby is getting adequate feed. Secondly, while breastfeeding, the mother will have her breast, which she will feel heavy. And after feeding, she will feel the breast to be lighter. That means the baby is suckling and getting adequate amounts of feed. If the baby is feeding well, the baby will be passing urine and stools properly and will definitely show weight gains also after 6 to 7 days.
Okay, thank you so much, Dr. Vishal. So coming back to Dr. Leena, could you quickly sum up the management of low milk supply? Would you like to give formula milk? Would you like to give galactogogues? So how are you going to manage her? Dr. Leena?
First of all, I would tell the patient, after we have ruled out that there is no physical problem in the breast, I would advise her to go in for more frequent feeding. There is no doubt that, more frequent feeding is likely to lead to a better output of milk. To encourage her and to ensure that she is feeding the baby properly. In fact, most of the time is, the proper positioning or the proper latching is not there, and that's why, the baby only takes the amount of milk that is there in the nipple, instead of, being able to suck that well and have the milk let down in a proper fashion. So that would be important for me to assess. And in case the baby is not latching, then we could have it expressed by hand or with the use of a breast pump. That could help us. Most of the time, it is very ineffective. Expression of milk is what affects milk production. Yes, there are some galactogogues, and the common thing which used to be told is methi dana. People used to boil water in it and put methi dana and strain it, and used to have the lactating woman have that. So what I would like to tell them is the good food that you have, make sure that it is you use coriander, we are using jeera, we are using soft. These are the things that should be there in your diet, and that is what I would tell them, that you could use that. We have a lot of other galactogogues available now, and they are very common. They're very nice and they taste well, so there's no harm in asking her to use them. Like you have Lactair, you can mix a couple of teaspoons in milk, and this way the lady would also have 2 glasses of milk in a day. So that would be what I would tell them. And of course, there are some drugs. We are also using domperidone, and that we give it to the patient 3 times a day, and that works well. So it's a combination of both galactogogues, both the natural and the ones that are available in the market, plus maybe drugs, like safe drugs like this, which we can give it for a short period of time for a good milk letdown. But what is very important to reiterate is you must continue to feed at the frequency that I just mentioned, so that the baby, the good milk letdown starts coming in.
Thank
and
you.
I always tell them that once good milk supply comes in, it will not stop unless either your baby is sick or you are sick. So that gives them the confidence.
Thank you. Reassurance plays a lot of part in this, and thank you for the excellent answers and delivery. We move on to our next case. During the rounds, you notice the attendant feeding formula, the newborn of a primary. Can you please mute yourself? Everyone, please.
Dr. Asha Rawal, can you please make yourself mute?
Hello.
It's giving lot of disturbance, ma'am.
So during the rounds, you notice the attendant feeding formula milk to the newborn of a primary para mother who is day 2, full-term normal vagina. She says that the baby is latching onto the breast and is unable to suckle. So how will you proceed and how will you counsel her? Dr. Surekha Jain.
Hello, good afternoon everybody, and I'm really fortunate to be part of this discussion. So ma'am, if the vaginal delivery has taken place and the mother is not able to latch, so there are so many reasons of her baby not latching. First of all, sometimes mother herself is not very much willing to feed the baby. But we have seen it so many times. If the mother doesn't get the desirable... Hello, Dr. Rawal, can you please mute yourself? Thank you, ma'am. Suppose she doesn't get the desirable sex of the baby, we have seen so many times that mother is so offended by, so anxious that she will not like to feed the baby. And then we have to really counsel the mother. We have to really take her in confidence and tell her how much important is this breastfeed for her child, and to in future, if she wants to take a proper care of the newborn, she has to really breastfeed. The other possible thing is that she is not properly able to know what is the exact position of the baby and how to latch. So your staff, doctors and housekeeping, everybody should know how to do that. For latching, we have first to make the baby have to skin touch with the mother. So the minimum of clothing should be there. Sometimes in winters, what we do, we just over clothe our baby, and when the mother is holding the baby, there is a lot of distance between the baby and the mother. So what we should do, we should take away the clothes and then finally cover the baby with a blanket and then try to latch. Second thing, the mother should support the baby. There are so many other positions as well, so that the baby feels secure. The baby should be held in such a way that the head is here and the foot is here and the hip should be supported, so that the baby is not insecure that the baby may fall. So we have see, these are the positions. The baby should not feel that baby will fall.
Dr. Surekha, can you just emphasize on how the baby should latch on?
Okay.
Latching.
Okay. Then for the latching, we have to just take out little milk from the nipple and then try to latch so that the lower lip of the baby is touching the areola. And then the nipple goes into the mouth and touches the palate. And as soon as the baby just tastes the milk, it starts sucking. And with this sucking, the vacuum is created and the milk keeps on coming to the baby. And so the baby will keep on sucking from the mother's breast.
Thank you.
Here, you have to take consideration of this, so that the nose of the baby is not being blocked by the heavy breast, and the nipple should also have some part of the areola so that it is not injured while latching.
Thank you.
So
Thank you,
maybe
Dr. Yes, Dr. Surekha, thank you so much. So what we learn is that proper latching includes not only latching onto the nipple, but more importantly to the areola. That is very important. And now coming to breastfeeding positions, Dr. Manishikha, can you tell us about the breastfeeding positions, especially for post-cesarean delivery cases? Because normally what happens is we tell the mother is understood she's had an operation and she should be resting. She has too much pain. The baby will not be able to breastfeed. This is the normal thinking pattern. So could you tell us how?
So in that case, I'll quickly discuss two positions. Although latching we have already discussed, it's usually an asymmetrical latch with maximum lower black portion inside the baby's mouth. So let's discuss about the position, and I would like to show you this, that if a mother is in a cesarean, so in that case we can very well use the time of stitching to feed the baby. We use two rules to attach the baby. Rule number one is baby should be hugging the breast, and rule number two is tummy to mummy. So tummy to mummy and hug the breast is the formula to attach and latch the baby. So if we have a cesarean mother who is lying down and cannot raise the head up, we can simply place a pillow below her shoulder, and then we can take a baby. We cannot stand at this side, so we can simply stand at this side and help the baby to latch on using a position tummy to mummy. So we turn the baby towards the towards the mother. The mother can support the baby's head while we are also supporting baby's head, and we help the mother in latching on. So this is one of the positions which we can use when we are in first 1 hour post cesarean. Later, when the mother is roomed in, the baby can very well be positioned on the side of the mother, wherein we can again the same rule, tummy to mummy, hug the breast. We tell the mother to support the baby, and we can keep some tissue or some towel to support the baby's head, helping the baby to latch on the breast and feed. Definitely some guidance, some support is required while we are helping the mother to breastfeed in cesarean sections. One hour towards the head side, and other than that, we can use the sides and we can place the baby. One last position, and that is sitting. In sitting position, we can tell the mother to use a pillow to support her arms. Pillow is never to keep the baby down. The baby is never straight. और हमने मदर्स को देखा है कि वो सीधा रखती हैं एंड नेक को टर्न कर देती है towards the breast side. So we tell the mothers to turn the baby towards them, cradle their babies, and then help them to latch on with supporting the breast. We tickle the nipples over to the lips of the baby, and as soon as the baby opens a big mouth, bring the baby close to you. So
thank you.
Right. Pushing the nipple is not the way. It's always bring the baby close to you. Thank you, ma'am.
Thank you for the very important tips, Dr. Manishikha and Dr. Surekha. So while the patient has just had a normal delivery, it is very easy to put the baby onto the mother's chest, and the baby itself, crawls over to the breast, to the nipple, finds the nipple and starts to suckle. As far as cesarean sections are concerned, yes, one could try the football hold immediately while we are still stitching and closing the abdomen. The baby can be put to the breast by the football hold position. So which must be done, because that's the only way to start breastfeeding in the first 1 hour. As we all know that cesarean section rates have increased and it should be used. So how do we assess whether the mother is able to latch on or not, and what can we do? So we've already heard Dr. Surekha saying that we should assess whether the mother is anxious, is she at rest with herself, does she have a desire to breastfeed, how are her nipples, and what are the different positions. And the influencing factors would be how we educate the patient to position herself and to latch on. That is very important, including teaching the family also, because it's mainly the family which supports the mother once the mother is discharged. So encourage and reassure, and rooming is important, proper positioning and reassurance. Moving on to case 3, which is also very important, because in these days we have a lot of working mothers. So this is for you, ma'am, Dr. Anita Gupta. Mahima is a 36-year-old senior manager in the corporate sector. She comes to you 45 days postpartum. She's going to join office soon and needs advice about contraceptive options, and also wants to know which is the best formula milk brand. So she's basically not really worried about her breastfeeding, because she has been told by her family and friends that she should now switch over to formula milk. So how will you counsel her to continue breastfeeding? Over to you, Dr. Anita Gupta, madam.
First of all, Divya, I will talk to this mother and I will just tell her the benefits of breastfeeding and disadvantages of formula feeding, because then only she will be sure that she wants to. Then let her decide that, yeah, this is the beneficial for my baby, I should switch on to breastfeeding. The next part is I will be telling her about the maternity benefit acts, because she is working in a corporate sector. So we all know the maternity benefit act of 2017 says that the maternity leave has to be given for 26 weeks. Secondly, if only 10 people are working in that sector, and if she has been working for 80 days, more than 80 days or equal to 80 days, she can get these benefits. So second thing is this. Third, the crèche facilities has to be there if she is working in a corporate, if the company has employees more than 50. So that might, if she has those facilities, she can always talk to her employer. Third thing is, whenever she is at home, she has to breastfeed exclusively during night and during the time when she's at home. The fourth thing is she can express breast milk and keep it. And she can express at home also, she can express in the office also. And this express milk can be given by any caregiver. Naturally, she will need a family support, whosoever is taking care of her child if she has to go to the office. So that person can be taught to feed the baby with katori, not with the bottle or not with the spoon.
So our next question to you, Dr. Anita ma'am, sorry for interrupting, is how do we store the milk? How does she store the milk?
Okay, so what she can do, she can store this milk at room. If she is at home, she can feed the same after 4 to 6 hours. That it depends upon how many hours she will be out for her work. If she is out for longer time, then she can store it in the refrigerator. She can express in the office also, if the employer has given some facility for lactation room, for privacy, some fridges there, so she can keep there also, and this milk can be kept at 24 hours in the refrigerator, and she can bring home and can be fed to the baby. And when she's going back home to the work, she can leave this milk in the house also, and that can be fed.
Thank you. So when she goes back to work, she should ideally be given a private, quiet, clean room where with a refrigerator, preferably in that room. And otherwise, you can carry her cooler bags, those freezer ice packs that we have, and she should continue to express milk even while at work every 2 to 3 hours. That is very important. So therefore, providing her a room and some refrigerating facility is very important also. And of course, these days there are a lot of flexible work hours, and working from home has become the norm. So she should make use of that. And then what is the rule of 3, 4, 5? Madam, could you just tell us that?
So actually otherwise we say 4 to 6 hours, but in our condition, like summers, it's so hot, so we usually make it a rule of 3, that 3, and it's easy to remember also, that 3 hours she can keep it in the room temperature, then 3 days in a fridge, that refrigerator, the freezer part, and 3 months in the deep freezer. So, and the refrigerator 24 hours, as I said. Just in a normal place, it can be 24 hours. Otherwise, the rule of 3 can be given.
She can even start storing her milk in small tubes like these, in these containers, before she's a month prior to she starts going back to work. So this is also another very important tip, and it's called insurance pumping. And then what about breast milk thawing? So suppose we've removed the milk from the freezer. So how long can we keep it outside?
Actually, we have to, if it is coming from the refrigerator only, as I said, 24 hours, it has to be kept for 1 hour in the room temperature, and then she can feed the baby. But we usually say direct heating of this milk is not advisable. But usually we don't say heating is required. But if sometimes the baby is cranky and you don't have 1 hour time, you have forgotten, or baby wants the milk early, so that time she can keep the milk in a heating water bath, and there she can water bottle, and then she can heat it.
Thank you. Yes, ma'am. Yeah. So thank you. So thawing in a container containing lukewarm water is the right way of kind of rewarming the milk, or bringing it back to room temperature.
If needed. Otherwise, room temperature is enough.
Thank you. So we move on to the next case, which is for Dr. Kusum and Dr. Vishal Jain. Payal is a 34-year-old girl, a lady who gave birth to a preterm and FGR baby by LSCS. The baby weight is 1.3 kgs at birth, and the gestational age is 31 weeks. Baby is admitted in the NICU. Mother was prepared for breastfeeding during antenatal classes. Now her concern is how and when can she start breastfeeding her baby. So will you wait till the baby is discharged, or what do you say, Dr. Vishal Jain? When should we start sending express breast milk from the mother to the baby?
Ma'am, we will not wait for the baby to be discharged. Breast milk is basically the most important part in the care of the preterm. It is a gold standard. So we would like to express breast milk as soon as possible, probably within 1 hour. And they will like to start the baby on orogastric tube feeding, and in that we would like to use the express breast milk. If the baby is hemodynamically stable, we can directly start the baby on total feeds, total express breast milk through orogastric tube. Or if he is not ready to accept the feeds totally, then we can start on trophic feeds. But everywhere, express breast milk is required, ma'am.
Thank you. Dr. Vishal. Dr. Kusum, how many times are you going to ask the mother to express her breast milk, and how is she going to express the breast milk, manually or with pumps? And she's already complaining that she's unable to produce enough milk. So what do we do for all these problems?
As far as insufficient milk is concerned, it has already been discussed. And especially when the woman is trying to express it manually, the chances are that initially the flow is going to be very less. In the first 1 or 2 days, it may be just 1 or 2 milliliter every time. But then we have to encourage the patient that this colostrum may be less, but it is important for the baby. And she doesn't have to give up. She has to understand that the more she expresses, more the milk is going to be. Plus, she has to be stress-free, because when she's more stressed about the baby, then the stress also works on all the hormones, and the milk production may actually go down. And in our country, most of the times after delivery, the patients are told to drink less water for whatever reason. I don't know, everyone has a, bulging tummy, but still they will tell their daughters-in-law not to drink water because pet bahar aa jayega. So they have to be told that they have to be nicely hydrated. Only then the breast milk will form. If the patient is restricting on her fluid intake, the breast milk is going to be difficult. Now, as far as how to express, I feel initially it is the manual expression under guidance of something like Manishikha, that it can start forming the milk, because once we empty the breast, there is a signal to the brain that more milk is needed. So it's a kind of cycle which forms. If you express more is formed. The signal goes to the brain that milk is in demand. While on the other hand, if the woman is a little lazy or not so convinced about expressing, and the breast remain full, in that case, the brain gets a signal that, this milk flow is more than required, and there is a kind of a negative feedback and the flow reduces. But in some patients, and especially when the baby is going to stay in the NICU for long, it may be very tiresome to do it with, manually. In such patients, sometimes a manual pump or a mechanical pump or an electric pump may be of use. But somehow it is my experience that when you use a breast pump, the nipples get slightly edematous. So the lactiferous ducts which are opening on the nipple, they become still narrow. So I feel if they learn to express with hand, there's nothing like it, because they can really, express it very nicely. If you show them, the milk goes almost more than a foot uh, when you do it. So if they know and they can do it and they understand it, and most importantly, if they are willing to breastfeed.
Thank you. Thank you, doctor. This was an excellent roundup of the whole thing. So there are guidelines formed for breast milk feeds for preterm babies by ACOG and other organizations. And it says, breast milk is particularly important for preterm and low birth weight babies as it provides complete nutrition. Breast milk is the gold standard of care for preterm babies. Preterm babies who are fed on mother's milk have less incidence of necrotizing enterocolitis and less incidence of late onset sepsis, RDS, retinopathy, less need for ventilation, better neurological outcome, and lower mortality rates. Kangaroo care is another thing which should be promoted and because it promotes frequent suckling and helps in maintaining the baby's body temperature. Preterm babies should be given express breast milk through tube feeds, as Dr. Vishal has already emphasized on, and encourage the milk's expression 8 to 10 times a day. Domperidone can be prescribed to enhance milk supply, involve mothers in a day-to-day NICU baby care. So the mother should be told to go to the NICU to see her baby, to do bit of baby care, which means daily suckling at emptied breasts, regardless of infant weight or gestational age. That also encourages the letdown reflex for milk. And 2-hourly breast expression for milk is required, which may be night and day, which has to be night and day. So this is a small baby, a preterm baby, as we can see, and the mother has her hands on the baby, but the preterm baby also needs the mother's affection, perhaps even more than a full-term baby. And so he needs his mother day and night. And that is why kangaroo mother care is a very good option, which hospitals should practice. And this is something which is already going on in Safdarjung Hospital. We had the fortune to go and see all this. Now coming to case 5, which is the last case, Dr. Asha Rawal, Dr. Asha Hans. Madhuri is a primary who has had a full-term normal delivery 3 weeks back. She comes with complaints of throbbing pain and a lump in the left breast and fever. So what is your diagnosis and what investigation will you get done to confirm your diagnosis? Dr. Asha Rawal, are you there, ma'am? Dr. Asha Hans?
Yes, ma'am. Yes. Thank you, madam. Thank you for making me a part of this important discussion. This is a patient who has come to us with pain and lump and fever as well. First, and she is lactating woman and postpartum. So my first diagnosis would be stasis of milk would be there. So my first diagnosis would be breast abscess. Like it would be, my diagnosis would be breast abscess.
Which, if you want, you can confirm with a...
yes, we can have battery of investigation. We can go for a CBC, complete blood count, and ultrasound.
Yeah, because sometimes the breast abscess is deep within the breast tissue, so you're not able to actually palpate it or perceive it. So what will be the course of management? Would you like to do aspiration or an incision and drainage, and why?
That depends on ultrasound findings. If ultrasound finding shows me this is unilocular and to me it is small breast abscess, we can aspirate it with 14 to 16 gauge needle. And if it is unilocular, we can just aspirate it and put the patient on antibiotics or for 5 days, and we can follow up with the patient. If this is multiloculated and still it is small, we can try aspiration as well with the 16 to 18 gauge needle only, and then but in this case we have to go multi-directional so that there should be no septa and all the septa should be broken up, and we can make a slide or we have to confirm our diagnosis, and as well as we can send it for culture sensitivity in case my antibiotics don't work later on. So that might
Okay, thank you so much, Dr. Asha Hans. And this is something which we as gynecologists can also do, aspirating the breast abscess under ultrasound guidance if required. So what are the advantages of aspirating over incision and drainage?
Since it is aspiration is a closed procedure, and patient is it is minimally invasive, and definitely it avoids hospital admission. Financial load is less, no painful dressings, and obviously since they are females and cosmetic outcome is much better with the aspiration, and their recovery is so fast and they can continue their breastfeedings, no dressings. So that is definitely a lot of advantage over IND.
Excellent. Thank you.
Might need admission also, although it is sometimes we keep, since in our hospital sometimes it is a huge abscess or large abscess. In those cases it might need 24 hours admission, or and financial load is as well on the patient. Recovery is also late.
So we can also, in fact, we may need to do an incision and drainage if required. So
yes.
So we end with this, and the key messages are that only less than half of the infants globally are breastfed within first hour of life, and the formula milk rates are still on the increase. So we have to promote breastfeeding. We have to make sure that the family is supported, because it's mainly the family which supports breastfeeding of formula milk. So everybody has to be taught together antenatally during antenatal checkups. We have to make sure that the patient is asked to understand the benefits of breastfeeding and promote breastfeeding. Thank you so much. Over to you.
I just want to make one comment that if Dr. Vivek Jain is still here, at least, he being the head of neonatology, so we all can put, a combined request for to the anesthesia department also, so that the baby can be kind of either breastfed or at least skin-to-skin contact. The basic issue is because that area is generally cold, and we cannot bring a moist baby to a cold environment to keep a skin-to-skin contact. So we can definitely have some way where we can do it. And the second thing is that we are really lucky that, if the baby is not on any kind of support, especially the respiratory support, our NICU is really good that if the baby is more than 1200 grams or more than 32 weeks, they always give breastfeeding. And if tube feeding is going on, then trophic feed is started very early. So, Dr. Vivek Jain, his team is doing a great job. I'm not saying Dr. Vishal Jain is not doing, but because I don't have any experience with him. So it is all Jains who have captured the NICU.
No, thank you very much, ma'am.
Then we'd like to know from you. Yes, please.
So, ma'am, actually, there are a lot of, issues which we come across when we try to establish breastfeeding in the OT. There's a lot of resistance which is, there from some of the anesthesia staff and at times from the even some of the gynecologists also while they're doing the procedure. But we have tried to establish it कि हम OT में ही चालू कर पाएं. But so far we have been able to give that golden hour feeding to a lot of our babies, despite of not having much of success in breastfeeding the baby in the OT. Hello?
Yeah, you are audible. You're audible.
Yeah, right. So in our NICU in Fortis Shalimar Bagh, we try to establish breastfeeding ASAP, and I'm proud to say, with the support of the lactating team, more than 90% of the babies which we send home, they go on exclusive breastfeeding. And I would say 80 to 90% of such babies are still breastfeeding exclusively till 6 months of age. And again, it all credit goes to the team effort. And the baseline and the most important aspect is the obstetricians. When they counsel the mother and reinforce the things from the antenatal period, counseling is the important part is, and not only the counseling of the mother, it is the counseling of the family which takes more important role, because mother is not in that state of mind. तीन लोग आके बाहर से बोलते हैं, and then she gets demotivated. So it's very, very important that the obstetrician they reinforce the things to the mother during antenatal visits, postnatal rounds, and then we must have lactation support as we have in our hospital, and I think most of the hospitals do have it now, who dedicates that time in first 1 or 2 days of life. And we as a rule, हम हर मदर को यही कहते हैं कि अगर आपने यहाँ से breast feeding नहीं सीख के गए hospital से, तो you are not going to succeed. And then calling them on follow-ups on regular time, even at times of a complimentary visit, just to reinforce things. कि वेट चेक कर लेंगे हम आपका. फॉर एग्जांपल इन आवर सेटअप वी प्रोवाइड देम सम ऑफ द कॉम्प्लीमेंट्री विजिट्स कि आप हर 2-3 दिन 5 दिन जब तक वेट गेन नहीं होता वेट चेक कराने आते रहिए, and then we won't charge you also, so that we can reinforce the things and motivate the mothers to breastfeeding. So that's what we do, and it was a wonderful webinar, I would say, and a very good initiative, ma'am. And I think it will go a long way and definitely help us in improving our breastfeeding success rates.
I think Dr. Vivek, we can start kangaroo care also.
Ma'am, we do it. We have been doing it.
We keep motivating women who have their babies in NICU to go and visit their baby, sit with the baby for some time, hold the baby. Because that definitely, the mother feels she is in control. She can hold the baby, she can breastfeed whenever she wants. And, she can roam around and do her other works also.
So we do practice kangaroo mother care in our unit, ma'am. So we don't, at times we don't really label it as KMC, but we are already accredited by NF level 3. We can't get an accreditation without providing a KMC to the such sick preterm babies. We provide KMC to babies on CPAP also at times. Sometimes we have certain babies who are not getting off CPAP. We provide them KMC and they start getting off CPAP. Yeah. So it's a routine practice in preterm babies, which we do provide. As soon as the mother is in a condition to go near the baby, we encourage it. And as far as mother's handling, as you correctly said, it is very, very important that mothers feel that she's in control of the situation right from the birth. So we always motivate them कि आपने देखा भी होगा, for the preterm babies when they are very tiny also at times when they are 500-600 grammars. तो हम उनसे कहते हैं बाकी सब हम कर लेंगे, but आपको अपना milk भेजना है. And then she should meet whenever possible, touch her baby, hold the baby as soon as the baby is stable, and provide skin to skin contact. And we start providing even at 750-800 gram babies. But as soon as they are stable, they are off ventilators, they are off inotropes, we provide them KMC.
Thank you so much,
ma'am.
Anita, yes.
I would like to add one thing, Dr. Vishal and Dr. Vivek. Thank you very much that you people are doing such a great wonder things. This Shalimar team has also been trained by me only, the lactation people who are working with
Thank you so much, ma'am. Thank you,
you.
ma'am. Thank you.
So the one thing I wanted to add here, what happens, you always, in the first 7 days or 10 days, 14 days, you say the weight loss is there. Okay. And that time we cannot assess the enough milk because the weight gain is not there. Still, the urine output is also not that way there in the beginning. So most of the people, what pediatrician will tell me, oh, it's 12%, ma'am. Now we will start the formula feed. It's 14% loss. We are going to start the formula feed. But at least, so this is happening. What I am just telling, not in your setup. I just said it's great. You people are doing it. So what happens, we have to learn this, that 14% we have to tell, supplement the breast milk only. If the baby is not gaining weight, just supplement the breast milk rather than just switching over to the formula milk. So which is really happening with gynecologists also. They also say, "Arey, pediatrician ne keh diya 14% kam ho gaya. Arey to formula de, tera doodh nahi aa raha hai." So that's really a really important thing that we should tell them, supplement your milk. Baby might not be able to attach properly. Naturally, we have to teach her how to attach, how to give the proper milk, but supplement your own milk and then the baby will gain. No formula at least.
Absolutely, ma'am. Absolutely. And as you said correctly, up to 15% of weight loss or 16% of weight loss can be accepted also. But we just need to keep the baby under close observation. We tell them, you come back for a repeat follow-up. We'll see the baby again tomorrow. If the baby is active, you express the milk. And you keep on giving the milk. So that is the way forward. 12-14% weight loss is not a criteria to give formula.
Yeah.
Kusum, ma'am.
How important is the human milk bank? And should we have one in Delhi? And what do you think of it, ma'am? Dr. Sharda Jain, ma'am, Dr. Vivek Jain, all the experts over here.
Quite a few hospitals have this human breast milk bank, And I think there is a need that more and more busy units should encourage this particular bank.
Actually,
so we do
Lady Harding has got a milk bank.
Yes.
And La Fame has also got a milk bank. But still, it should not commercialize. We should not think that the mother is not able to breastfeed. Go and bring it from the milk bank. At least it's for the premature and the sick babies also.
Correct, ma'am.
Doctor, I differ with you here, Dr. Anita here. That, sometime you find, there are, if in the city of Delhi, there's so many births are taking place. Safdarjung Bank and Lady Harding Bank and La Femme Bank and one or two more banks can't take care of things. So I think, the decision has to be jointly made.
Yeah.
See, what I'm trying to say, express breast milk now can be sent, and when the things are available, instead of a formula milk, when 1 or 2 feeds are required, we can definitely do fortification with the this milk. There should not be something like this. ये तो होना ही नहीं है. होना नहीं है तो फिर तो formula ही लगेगा.
नहीं होना तो चाहिए, but commercialize नहीं होना.
Formula से तो ये जो आपके अभी 1 or 2 companies are there knows. If they are powerful in Australia, if they are powerful in US, तो हमारे लोग इतने strict क्यों होते हैं? Strict का मतलब है formula आ जाएगा फिर.
Ma'am, as you correctly said, when we talk about comparing like to like between mother's milk and formula milk, there is no comparison between the two. And when there is a given option कि formula है कि pasteurized EBM है, then pasteurized EBM is a definitely good option. Correct. But we've had lot of issues with pasteurized EBM in terms of कि mother आते कहते हैं वहाँ पे 150 रुपए का डब्बा 1200 रुपए मिल लगेंगे, हम लाके आपको देते क्या इतने चक्कर काटने हैं. So there are a lot of hiccups and issues which does happen. Fortunately, we do have a milk bank as name of Amara at La Farm, and we do use it, and it should be encouraged. It's just that proper counseling is required to the parents, and at some of the institutes, they sometimes start using pasteurized EBM for 2 kg babies also. कि ये better है जी formula से, which is obviously not good. So yes, it is definitely a need of hour, and we need to invest into it, both time and effort. So that we can, certain mothers जो आपके पास भी आते होंगे, मेरा तो इतना मिल्क आता है मैं फेंक देती हूँ. That's what they complain. हम dog को पिला देते हैं, हम इसको पिला देते हैं, which is obviously it should go to the needy babies.
Dr. Vivek, many mothers are coming to me nowadays. कोई अपने conference के लिए आई हैं या कुछ बाहर से state से also, they say where I can donate my milk.
Absolutely,
because I was feeding my child there. Now in Delhi, how can I donate? So there
But
must be, should be.
it is a complicated procedure, and I must
Yeah.
address it in this forum
Should-
that we can't just give one mother's milk to another mother without having it investigated, and testing needs to be done. It is like blood bank; it needs to be tested, and there are a lot of medical legal aspects to it. But definitely, it should be done with proper testing. It should be encouraged, and that's the way forward.
I'd like to say just one thing, that I'm really, really thankful to BPNI. When my daughter delivered the first time, the initial 10 days, she was, I don't know, she was so stressed out. She was not able to feed her baby. There was no lactation. She was be fighting with me that you should have told me earlier this, that. Then I took her to BPNI. They have their center here in Pitampura only. She really worked hard, and then, you know, the next pregnancy also, and after 1.5 months, she worked hard and she could breastfeed her baby. So, you know, counseling and directions and everything really, really helps.
Ma'am, nowadays the role of lactation counselor should be understood, because that is really need of the hour, and people should send them as a super specialty. It should not be that I can do it, because no one has got that much time to
Absolutely.
counsel.
Absolutely.
Counseling takes lots of time. That's
So
Correct,
Dr.
ma'am.
Manishikha,
Definitely.
she's a lactation expert and she wants to say something. She's raised her hand. She's the lactation expert over here.
Yes, actually, what I have seen in past 7 years, that any mothers or couples who have taken antenatal education, like we provide 3 to 4 hours of breastfeeding education for women who are pregnant. So I have seen that the percentage of them breastfeeding exclusively is more than 95%, and those who have not got the education, because see, we are no one to judge anyone, but there is society who is judging a new mother. You're not having milk, ये नहीं हो सकता, वो नहीं हो सकता, bottle तो देना पड़ेगा. So I think information is the first and the foremost thing जो कि mothers and families को मिलना चाहिए, because mother will still do it, but it's the family which has to be taught. Has to be.
Yeah, thank you. Thank you. Dr. Surekha has raised her hand. Dr. Surekha. Please unmute yourself. Please unmute yourself.
Many families, they say that let the baby feed by a bottle. Why? Because the mother will go after 1.5 months or 6 months or 6 weeks for her job. And so how we will feed the baby? So we have to really counsel them about preserving the milk, which they do not know exactly. Most of the females who are working in the office and not getting long leaves, they say that let me try about the bottle feed so that my child can get feed when I'm away from the house. So this is a big problem.
No, madam, this big problem can be addressed by the antenatal counseling and training. That's the time to do it. That's the time when she comes 4 or 5 days. Not only she comes, her husband comes or a family member comes, and that is the one which is going to be successful. I presented to you the US study, but that study holds good everywhere. Just now, madam, Manisha has also said that, 90% people who have counseled had an effective lactation. And this is where the crux lies. If her theory is sound, she is going to be breastfeeding.
Right.
And it takes only one week to learn how to feed with the katori. So no need of starting a bottle in the beginning and giving her the baby a nipple confusion. So baby will not latch again. So that's a problem.
This nipple confusion which Dr. Anita is talking about is very, very important. क्योंकि एक बार बच्चे को सॉफ्ट निपल मिल गया तो वो तो कभी भी ब्रेस्ट ट्राई नहीं करेगा. मैं तो हर बार बोलती हूँ कलयुग के बच्चे हैं भैया, ये काम नहीं करना चाहते.
मैम सॉफ्ट से भी ज्यादा, बिकॉज उसमें कुछ करना नहीं है, आता रहता है.
हाँ, easy milking of
they become lazy like humans. Like they are human babies.
मैंने
They are lazy like humans.
Human nature. अगर चीज आराम से मिल रही है तो मेहनत क्यों करना है?
One point I want to highlight is since we see the patients antenatally also, in 7th month, I think we should make a policy. Sharda ma'am should say.
So what I feel is the bottom line is gynecologists must train themselves. Must train themselves. BPNI training may be expensive, but I think, let's have a training and पहले empower तो करें आपने को. हम खुद ही empowered नहीं है, इसलिए हम incompetent है. We are not sure. तो अपने को पहले तो ट्रेनिंग लेना पड़ेगा, ट्रेनिंग लोग, और उसके बाद तो फिर आपको नर्सेस की ट्रेनिंग अलग है, आपकी ट्रेनिंग अलग है, पहले आप तो खुद लो भाई.
Ma'am, one more last point I want to add. People who there are methods to actually breastfeed.
One at a time.
So yeah. So
I think we should examine our patients in 7th month or 8th month. Breast examination should be addressed, and it should be done by the gynecologist, so that retracted nipple, inverted nipples, people come across these problems later on when they are feeding. They show me their nipples and then they say, this is the problem, madam. Then it takes me so hard, 15 days, 20 days. इतने में तो वैसे ही breast भी सूख, उसका दूध भी सूख जाएगा. She is so helpless again. So I can't help that much. So I come across so much problems. So in my hospital, I have
आपका एरिया ही नहीं है, आपका एरिया काउंसलिंग का बताना का, और ये बताना चाहिए भाई ये लोग एक्सपर्ट्स अवेलेबल, यहाँ पर आपको बताना, आपको एग्जैक्ट बताना पड़े, इनसे आप हेल्प ले लो, which who are readily available.
Yes, we are taking help, but if we will examine in 7th month or 8th month, we can avoid these problems.
Examination मना किया नहीं, आप एग्जाम एक बार क्यों 4 बार एग्जामिन करो भाई.
Ma'am, hypothyroid patient on 75 micrograms, can she breastfeed her child?
Yeah.
Oh,
Yes.
okay. Thank you, ma'am.
So we'd like Dr. Surekha to give the vote of thanks. Thank you so much for this excellent deliberation and interactive session. Thank you, ma'am. Over to you, Dr. Surekha.
सुरेखा कुछ तो बोलो.
I think Dr. Surekha is probably not available. So I would like to thank on her behalf, I would like to thank Dr. Sharda Jain ma'am for being so proactive and taking, such simple topics which are generally neglected. We all, we hardly have any meetings which discuss about counseling for breastfeeding and issues on breastfeeding. Yeah, thank you so much, ma'am. And I thank Dr. Sanjeevani ma'am, Dr. Divya, and all the panelists. It was a wonderful discussion. We got to learn so many things. And when we are to prepare for it, then also we learn so much because we have to read so much about it. Thank you very much.